In the production process of eye prosthetic, the majority of eye prosthetic production is still processed manually and conventionally, the same as 50 years ago. In conventional eye prosthetic, many obstacles are encountered, such as patients require a relatively long manufacturing process and a visiting time of minimum 3 until 4 times. If the prosthetic result after the production got defects and poor quality, then the process must be repeated from the beginning. In terms of quality, because of the iris is colored manually, it tended to have a stroke and pupil deep like a real eyes. This due to the limited manual technology. Knoh 3D eye prosthetic applying Industry 4.0 technology by conducting research and product development in the medical field, especially in the eye-related field. We are developing eye prosthetic with 3D technology. There less interaction with patient is required, and of course, a faster process. Right now, we are open the collaboration with hospital, clinics, and ophthalmologists throughout Indonesia and Southeast Asia. Please contact us.
Good morning, good evening, and good afternoon, ladies and gentlemen, respected colleagues and delegates. I'm Dr. Tri Rejeki Herdiana, an oculoplastic surgeon from Jakarta Eye Center, Indonesia. I'll be your host for the next 2 days of events. We are honored to welcome all of you to the third APSOPRS INA-SOPRS webinar. Our second APSOPRS webinar was held on September 26, 2020, and this is our third webinar with the title Overcoming the Challenges in Oculoplastic and Reconstructive Surgery. This event is fully supported by Knoh 3D Eye Prosthetic, the first fully commercial 3D printed eye prosthetic in the world since 2019 and managed by Kulon. I would like now to introduce Dr. Dong Mei, our current president of APSOPRS, and Dr. Yunia Irawati as an organizer of our today webinar and also INA-SOPRS president to give some opening remarks and welcome introduction. Thank you, Dr. Dong Mei. The time is yours.
Thank you. Good morning, dear friends. It's my great honor and a privilege to welcome you to the APSOPRS series webinar. This APSOPRS Inner SOPR joint webinar. We are fortunate to have the support of Dr. Yunia Irawati and honorable guest speaker from all over the world and gathered in cloud. Just under the pandemic of COVID-19, APSOPRS has continued to propose the process in this period of the uncertainty by holding series webinars. So doctors at every career stage, from beginners to experts, can benefit from the impressive lecture and discussion. So I have confidence to to believe that you will find the novel idea, fresh energy, and cutting-edge techniques in this 2 days webinar. Many thanks everyone for your support. Welcome everyone to join this webinar. Thank you. Thank you very much.
Dr. Yunia Irawati, please.
Thank you, moderator. Good morning, good afternoon, and good evening, everyone. First and foremost, it is my pleasure to welcome all participants today for the third webinar of APSOPRS and in conjunction with the INASOP 2021. More than the 900 participants from all over the region have joined us, and I'm beyond grateful for the enthusiasm. Thank you for both Asia Pacific and Indonesian teamwork to making this webinar possible. Our deep gratitude for the APSOPRS President, Dr. Lee Dong-mei, APSOPRS Founding President, Dr. Reynaldo Yafate, and our guest speaker, Dr. Peter Drummond, Bobby Korn, Don Kikawa, and Naresh Joshi. And of course, all our eminent speakers from APSOPRS all over the country. You have come here to share the knowledge and vast experience for all of us. And the theme of the 2 days webinar is overcoming the challenges of oculoplastic and reconstruction surgery. This meeting will be focused on the presentation and case-based discussion for the socket reconstruction and the congenital anomalies. And then the second day, we have aesthetic eyelid surgery and rejuvenation. Each panelist and speaker will share their experience, unique cases, along with their expertise and manage various cases. Hopefully, this webinar will be good way and share current update in socket reconstructive and the congenital anomaly, and also the aesthetic eyelid surgery and rejuvenation, while also keeping a good connection between plastic and reconstructive society all over the world. And on behalf of everyone involved in this webinar, I hope you can enjoy in good stock. Thank you. Thank you for coming and join with us. Thank you, moderator.
Thank you, Dr. Dong-mei and Dr. Yunia Irawati for the heartful welcome message. Today webinar topic is socket reconstruction and congenital anomalies divided into 2 sessions. The first session, the expert will give their 10 minutes lecture and 2 minutes discussion. And second session, the young ophthalmologist will present a 5-minute case followed by discussion with our panelists. I would like now to introduce our chairman and co-chairman for our first session, Dr. Farzad Pakdel. Dr. Farzad Pakdel is Associate Professor of Ophthalmology Oculofacial Plastic Surgery in Tehran University of Medical Science, and Dr. Hoseoksa. Dr. Hoseoksa is the current Secretary of APSOPRS and Associate Professor of Ophthalmology Division of Ophthalmic Plastic and Reconstructive Surgery, Asan Medical Center, University of Ulsan, Seoul, Korea. And our chairman and co-chairman for our second session, Dr. Ashok K. Gruber, is a President Oculoplastic Society of South Asia and President Ocular Trauma Society of INIDA, and Dr. Santi Busuri is a consultant division of reconstruction oculoplastic oncology department, Cicendo Eye Hospital, Pajajaran University. I would like now to invite Dr. Farzad as a chairman for our next session. Dr. Farzad, please.
Thank you very much. Thank you, dear colleagues. Thank you, Dr. Yunia and Dr. Hoseok for arranging this wonderful meeting, and thank you for the president of the APSOPRS for supporting such wonderful meetings. It's a privilege for me to be here. So in the first session, we will start with the difficult subject in oculofacial plastic surgery. That's the socket, especially in the children. This is a no man's land actually in our firm. So we have great experts here, and I hope we have good discussion and good actually informative session here. So Dr. Hoseok, can you please start for the next actually session speaker, please? Please unmute.
Okay, my name is Hoseok from Seoul, South Korea. It's my privilege to help Dr. Pakdel to moderate this session. So we have 9 speakers, and all speakers are very well-known experts. I don't need to introduce them in detail. And if you have any questions or comments, please type them in the chat box, and we will have Q&A session after each presentation. We'll get started with Dr. Ashok Grover from India. The subject of his talk is contracted ophthalmic socket management algorithm.
Good morning or evening, everyone. Thank you, APSOPRS, President Dongmi, APSOPRS, Dr. Unia, and her team for this opportunity to be a speaker at this wonderfully organized meeting. I shall be offering an overview of management of the anophthalmic socket by an algorithmic approach. This is essential in order to focus on the appropriate area to be tackled in a given case. When we speak of a contracted socket, the first thought is that of a socket which has been scarred and contracted. But there is much more to sockets than just contraction, which we need to look at. Before we look at individual anomalies, it is pertinent to look at the literature, which shows that there are a number of symptoms and signs which affect the socket, and deficiency of conjunctival fornices is just one of them. An evaluation of the socket is important. And before we do that, we need to understand what we need in a normal, functional, and aesthetically acceptable anophthalmic socket. An adequate, healthy mucosa, eyelids of normal length, appearance, and tone, and a satisfactory central implant with a well-fitted prosthesis in the absence of an enophthalmos, and adequate transmission of motility to the implant are critical. With those in mind, you need to examine the eyelids, the socket, including the surface, for all the changes, all the accessory changes that are taking place before you get to your final decision making. The decision making can be an algorithmic approach. Once you have evaluated, you can classify your conditions into those where there is an inferior phonic shelving or a lag socket due to changes largely due to gravity, or they may be surface loss or abnormalities which may have caused a contracted socket, or there may be other associated anomalies which we shall discuss. Volume loss may be another significant problem leading to sulcus deformity and enophthalmos, and associated eyelid conditions such as ptosis, entropion, and ectropion may be other factors. We look at how we can manage each of these one by one. If the socket is lax or there is a shelving, you need a certain kind of management. As we know, this change takes place as what is called a post-enucleation socket syndrome, with the gravity causing the contents to come down and forward, resulting in shifting of the tissues and involutional relaxation of the eyelid supports. This is the appearance that the patient presents with a socket which is very shallow, and the eyeball tends to move down and out. When we pull the eyelid, we can see that there is enough mucosa, but not enough depth. And in these cases, you may require an eyelid tightening and formation of the fornix, either with a closed or an open method. I will skip the lateral tarsal strip procedure as it is well known to everyone. The fornix forming sutures start by identifying the point where the inferior fornix is to be created in the sac. So you put a prosthesis or a conformer and identify the position from where you want to create the inferior fornix, and you pass double arm sutures coming out through the eyelid or any of its modifications and pass it through a bolster and tie with moderate tightness. A bite taken through the periorbita is important. Now, the open method combines this with a lateral incision, which allows an undermining in the region where the adhesion is to be created, that is in the region of the inferior fornix depth and towards the bony socket, which allows a better adhesion to form and cause a more permanent result. An example is this shelved inferior fornix with the prosthesis tending to come out, and after the fornix forming sutures by an open method, it is retained securely. The surface abnormalities may involve contracted socket or associated anomalies. Let's look at these associated anomalies first. You may have conjunctival retention or inclusion cysts, and if they are causing a disturbance to the retention of the prosthesis, they may need to be removed. Chronic inflammation, congested sac with granulation tissue is another problem, and these may again require excision and sometimes a replacement with a graft. If there are symblepharon or fibrous bands, they may need to be tackled by reordering of the mucosal surface or a grafting. So this is a patient with a fibrous band not allowing the prosthesis to be retained, and this is particularly important in the superior fornix, causing a total shalling of the superior fornix. Since the patient was not keen on a mucosal graft, we did a Z-plasty. By reordering of the flaps, we could get a much deeper superior fornix. At the same time, the inferior lid laxity had to be tackled by an LTS procedure, which allowed a reasonable sized prosthesis and to be retained in the eye. Implant extrusions and exposures are particularly a problem in hydroxyapatite implants, where if the exposure is smaller, conservative treatment may be undertaken. But in others, either a conjunctiva tenon coverage or a scleral graft may require to be put. Once the trimming of the implant to create a flat surface is completed, an undermining of all the conjunctival and tenon surfaces is necessary so that a scleral graft shaped adequately can be placed after trimming with a coverage by the conjunctiva and the tenons in the periphery. This allows the graft to take up with, after the suturing is carried out, the subsequent epithelialization by the conjunctiva covers the implant. Where there is a contracted socket, you need to tackle it by looking at whether it is mild, moderate, or severe. The causes can be early, which may be due to the primary cause, such as loss of conjunctiva due to trauma or irradiation, or it may be due to absence of conformer in the early postoperative period. Late socket contractions often occur because of chronic infection, inflammation, or non-use of prosthesis for long periods. In mild socket contractions, prosthesis is still retained, but a lash entropion may start occurring, scleral show may start appearing. In these cases, the contracture in the fornices or near the lash margin may be managed by localized procedures. However, if the contraction is moderate, affecting both inferior and superior fornices, then we will have a poor motility, non-closure of the eye, appearance of enophthalmos, loss of normal lid fold, and persistent irritation and discharge. These cases may require surgical management or a combination of surgical and prosthetic management. Mucous membrane grafting is the mainstay of these cases. You need to take excess mucosa and create a good fornix formation, removal of the scar is integral to good take of the graft. This is an illustration of a patient who was operated twice earlier with a very significant contraction of the socket. After the central incision, an adequate scar excision, an adequate undermining up to the orbital margin and up to the lid margin are carried out. The bed is created, which is healthy for the graft, and the graft may be taken either from the lip or from the cheek. Sutured, secured in position, fornix sutures created, which allows a socket as contracted as this to have a much larger surface, retaining the eye with moderate motility. AMG is another possibility. However, the results have largely been mixed in different series. Severe contracture where mucosa is inadequate, at times it is a dry socket and an epidermal graft, virtually a slit left. In these cases, you may be able to use a split skin graft to useful effect, being able to retain some kind of a prosthesis. If there is volume loss and sulcus deformity, then volume augmentation may be necessary. This is due to decreased orbital volume due to a number of factors, and this is going to be dealt with by subsequent speakers, so I will skip the correction of enophthalmos. Where there is a combination of loss of volume and loss of surface, dermis fat grafting remains a very useful technique. Taken from the lateral aspect of the hip, with epidermis having been removed by creating a pudgy orange after injecting a little local anesthetic, an adequate sized graft is taken, secured in the bed, and works well. Finally, the associated eyelid conditions such as ptosis, entropion, or ectropion need attention. Ptosis may occur either due to volume loss or due to an injury to the localized levator palpebrae superioris. Lower lid laxity may also contribute. These usually require levator tightening, though sometimes smaller procedures such as prosthesis modification may work. Ectropion and entropion we have briefly already dealt with. That gives us the overview that the algorithmic approach allows us to identify the problem in a given case and deal with it accordingly. With appropriate evaluation, an algorithmic approach to planning and choice of procedure in most cases helps us achieve a reasonable cosmesis for a good psychological rehabilitation of an anophthalmic patient with a socket abnormality. Thank you very much.
Thank you, Dr. Ashok, for the great presentation and nicely framing the condition of the socket. So we have a question here from you. Do you have issue of lower eyelid edema post-fornix deepening suture? How do you avoid or deal with this?
See, the most important thing that you need to realize is that if the suture is too tight, it not just leads to a prolonged edema, it often leads to a local necrosis under the bolster. So the suture needs to be moderately tight, not excessively tight, which may cause the edema to persist. Of course, you can deal with it with the usual measures such as use of enzymes, anti-inflammatory, and steroids if necessary.
Thank you very much. It's essential when you tighten the sutures, do not strangulate the tissue beneath that sutures, as Dr. Ashok beautifully mentioned. So we can move on to the next speaker. Lucio, can you please introduce the next speaker?
Sure. So our next speaker is Dr. Peter Dolman from Canada. We all know him very well, and he is a clinical professor from University of British Columbia, and he is a past president of many well-known societies. So today's His topic is management of post-enucleation socket syndrome. And could you start?
I'd like to thank Dr. Yunia Irawati and her organizing committee from APSOPRS and the Indonesian APSOPRS for involving me in this conference. My topic is the evaluation and management of the post-enucleation socket syndrome, and I have no financial disclosures. The anophthalmic socket syndrome was first described by Visnes in 1976 and consisted of anophthalmos, superior sulcus deformity, lower lid laxity, and sometimes upper lid ptosis in patients who had a globe removal with prosthesis fitting. Over the next few years, additional features were included, including upper lid retraction and entropion, shortening of the fornices, and backward tilt of the prosthesis. The term post-enucleation socket syndrome was first coined by Tyers and Richard Collins in an article in 1982. These features can be quite troubling for patients with the syndrome, and they may often go to some lengths in order to disguise some of the features. In order to understand the pathogenesis of this syndrome, it's useful to review ideal socket elements. First, the implant must be of adequate size and centrally located. There should be a generous mucous membrane pouch to support the prosthesis, which should be custom fitted by an ocularist. Both the lower lid and upper lid architecture should be normal and functioning tightly. If the implant is small, this will lead to anophthalmos and downward displacement. As the implant sags, the superior sulcus will be deepened. This in turn will disturb the fulcrum or pulley system of the upper lid, leading to malposition. The ocularist may have to adjust by fitting a larger artificial eye, which will stretch the lower lid and shallow the fornix, lead to backward tilting of the prosthesis, secondary upper lid lag ophthalmos, and in some cases flipping out and loss of the prosthesis. The best way to avoid this syndrome, therefore, is to try to replace the volume of removed tissue with the largest implant possible. In an evisceration, approximately 8 mils of volume is lost and a couple of additional millimeters in an enucleation. On average, the deficit may vary from 2 to 7 mils, but to minimize this, the recommendation is a 20 millimeter spherical implant for an evisceration and a 22 millimeter spherical implant for an enucleation. However, placement of a larger implant does put strain on the anterior limiting tissues, which can lead to extrusion in PMMA implants or erosion in the case of porous implants with possible secondary infection. In addition, advancing the soft tissues over a larger implant may shorten the fornices and limit prosthesis fitting. The risk of these complications can be reduced by placing the larger implants deep within the orbital soft tissues. This can be facilitated by severing the ocular muscle insertions without pre-placing sutures that can get tangled at the time of implant placement, by retracting tenons and using glides of surgical gloves or drapes to avoid catching of porous implants on the tissue. I reinforce the anterior tissues by wrapping the implants with sclera or vicryl mesh, and I bring forward the muscles horizontally so that they meet each other and provide a vascular membrane that supports the implant and also provides a vascular layer that prevents a breakdown of overlying conjunctiva. Lastly, I leave the superior and inferior rectus muscles unattached because the fornices will move spontaneously as the lids go up and down, moving the prosthesis, and that will allow deeper fornices. For eviscerations, deep placement of a larger implant can be facilitated by dividing the scleral envelope into two leaves. I like to make a cut with a Westcott scissor between the superior and lateral rectus muscle superiorly and between the inferior and medial rectus muscle inferiorly to avoid the oblique tendons. Again, I use glides for porous implants. The scleral envelopes can be overlapped anteriorly to provide additional anterior reinforcement along with double closure of tenons and conjunctiva. An intermarginal suture helps prevent prolapse of soft tissues. Because eviscerations are often painful, particularly with a larger implant, I will often inject 1 to 2 cc's of retrobulbar alcohol just infratemporal to the optic nerve head. Despite one's effort to place a larger implant, features of the posterior enucleation socket syndrome may develop. An ocularist may be able to compensate by modifying the prosthesis to a remedy in upper lid ptosis, as shown here, or fill a deep superior sulcus, as in this patient, by a thicker rim to the superior artificial eye. I'd like now to present surgical options that can be offered in a staged approach for a patient presenting with anapthalmic socket syndrome. The first is to increase the volume filling the orbit, either by exchanging the implant for a larger one if there's sufficient conjunctiva, or placing a dermal fat graft in cases where conjunctiva is limited. Other options include a subperiosteal implant or injectable materials. The deep superior sulcus can be treated with dermal fat grafts or by deepening the opposite sulcus. And lastly, malpositions of the lower or upper lid have various surgical options. The first option in cases with sufficient conjunctiva is the replacement of a small implant for a larger one. This may not be too difficult for non-porous implants, but can be challenging to dissect free a porous implant. In cases where there is significant conjunctiva loss from erosion, consider a dermal fat graft, which allows you to suture the conjunctiva often just to the edge of the dermis and allow conjunctival ingrowth, thus deepening the fornices. One nice option which addresses both the anophthalmos and particularly the downward and backwards migration of the implant is to place a subperiosteal implant of acrylic or silicone material, which will push both the implant forward and upwards. Preformed shapes are available, which can be glued or screwed into position. And you can see that this may result in a nice filling of the superior sulcus and also allows tightening of the lower lid at the same time as the primary surgery. Various injectable materials, including silicone or hydroxyapatite microspheres, can be injected into the orbit and result in satisfactory filling of the superior sulcus. My preference is placement of a dermal fat graft, often in combination with some ptosis repair, as shown in this lady a week postoperatively, or in this gentleman with a fat placed on the left side. Notice that dermal fat graft will expand in size if the patient gains weight, as shown here, and so debulking of the fat was carried out. This young lady underwent an enucleation with prosthesis fitting, but notice the deep superior sulcus with a lid crease formation. And in this case, I elected to debulk and form a crease on the opposite lid. Lower lid laxity is best addressed by horizontal tightening, which may also lift the prosthesis and fill the superior sulcus. In this case, the lower lid downward displacement was repaired by lifting it with the scleral insert graft posteriorly. This allowed repainting and refitting of a prosthesis, which resulted in better horizontal symmetry. Finally, ptosis associated with the anophthalmic socket can be repaired through standard ptosis repairs. And secondary cicatricial entropions from fornicel tightening can be repaired by tarsal fracture and repositioning. In summary, we've reviewed the clinical features, pathogenesis, prevention, and treatment of the anophthalmic socket syndrome. And I'd be happy to entertain any questions. Thank you.
Thank you, Dr. Dorman, for the great presentation. So let me look at here. We have a question for you. How to maintain the depth of the fornix during enucleation or evisceration? I may repeat the question for you. How to maintain the depth of the fornix during enucleation or evisceration?
I think the two issues are not pulling the conjunctiva and tenons too far forward. And if there is previous surgery, for example, multiple retina surgeries and glaucoma procedures that have traumatized the conjunctiva, at the time you're enucleating or enucleating the eye or eviscerating it, I think it's really important to handle those delicate tissues as gently as possible and try not to sacrifice them. If there's some sort of explant, like a valve from a glaucoma procedure, I dissect the valve away, but keep the conjunctiva and tenons as intact as possible. A second thing is to place whatever implant you're using as deep as possible into the socket. And that often means, in cases of porous implant, using some sort of slide or glide so that you can, and distracting the side tissues so they don't catch on the rough surface as you're implanting the ball or the sphere. And then I prefer not to actually suture the superior and inferior recti muscles onto the surface of the sphere that you implant. The reason is that I think the horizontal ones, the lateral and medial rectus, as you bring them forward, will provide sufficient muscle coverage to protect the implant from, or protect the conjunctiva over it and provide a vascular supply to keep it healthy. And that helps prevent extrusion. But if you pull the superior and inferior muscles forward, sometimes that can result in shortening of the fornices as well. And in fact, the fornices move up and down very well with the movement of the upper and lower lids retracting. That up and down never seems to be a problem for the artificial eye, as long, even if you don't suture those muscles down. And then if you've got a situation where you just have poor conjunctival tissues to start with, then I think Dr. Grover's point of considering dermal fat graft instead of a ball as a primary placement or secondary placement after removing an infected or exposed implant is the best choice, because the dermal fat graft, as it's embedded, you don't need to cover it completely with the conjunctiva. You can cover the edge and it will often epithelialize over.
Thank you very
Dolman,
much.
yeah, Dr. Dolman, I have a question for you. So you mentioned the retrobulbar injection of alcohol after evisceration to control pain. So sometimes we see the patients with the painful blind eye glow, even though he has a pretty good volume of the eyeball. So do you think we can use that kind of alternative instead of doing evisceration for that patient?
Yeah, I mean, people, I think, have always considered retrobulbar injections of one analgesic or another to try to avoid removing the eye, and that's certainly a possibility. If you do, the alcohol injection can be quite painful at the time you inject it. So I'll often, I usually go through, put some topical anesthetic on the surface of the eye, and rather than going through the skin, I go through the fornix. I'll usually inject a little bit of lidocaine with epinephrine first, just to provide some analgesia, and then inject a couple of cc's, usually of retrobulbar alcohol. That's certainly an option. I do it always for eviscerations, and I do it at the time that you've already eviscerated the contents of the eye, and then you're looking right down at the optic nerve head. And then I inject it inferotemporally adjacent to the nerve head, maybe a millimeter away from it. I place it inferiorly so that you don't get migration superiorly that might lead to a prolonged ptosis or forehead numbness or paresthesia. It's less likely. And I place it temporally because the ciliary ganglion is on the temporal side, so you're more likely to get an effective analgesia. And we published a paper that shows that it really provides a week worth of or more of analgesia, and much more effective than something like retrobulbar marcaine or bupivacaine. So it's a consideration, I think.
Thank you.
So I may make a quick comment. Pierre, do you use the inferior oblique muscle to further strengthen and vascularize the implant during enucleation?
The inferior oblique?
Yeah. What do you do with the inferior oblique muscle?
I'm really a simplistic surgeon, so everything I've done in my career has been to eliminate steps, if I can, that I was taught. So I actually was taught to use the inferior oblique to help support the prosthesis up. I don't actually do it. So I only sew the medial and lateral rectus. As I said, I leave the superior and inferior rectus alone. I don't pre-place sutures because I found it's actually very quick if you if you're doing an enucleation, if you cut the four recti and the oblique muscles and don't put sutures on, when you remove the eye, it's easier because you don't have sutures tangling up. And it's always quite easy to find the medial and lateral rectus sitting there in the tenon sheaths. You actually find them quite easily. And I find that speeds up the surgery. I know many people support the idea of using the inferior oblique as a kind of a hammock to support the implant. And I see the logic in it, but I don't do it. And I have to say, I don't, if I thought I had to do it, I would do it. But I think I get good centration without doing it.
Thank you very much. So we have a couple of questions still there. So we may move on, and then we will come back if we have enough time for asking more questions, Pierre.
Okay.
So Dr. Hoshio, can you please move on to the next speaker?
Yeah, we're going to move on to the next topic. And the next talk will be given by Dr. Hirohiko Kakizaki from Japan. So he is a professor at Aichi Medical University, and he's a former president of APSOPRS. And his topic is congenital coloboma with limbal dermoid, embryogenesis and management. Could you pull up the slide?
The topic of my presentation is congenital both upper and lower lid, coloboma with limbal dermoid, embryogenesis and management. Today's topics are as follows. First is the development of eyelid, and the second is the management. First, I'm going to talk about the development of eyelid. Development of eyelid takes 5 stages, beginning at week 6 of gestation. Stage 1. Development of eyelid fold, which occurs with the migration of the ectoderm over the developing lens vesicle. Stage 2. The eyelid fuse over the globe from around week 8 of gestation and remain to months 5 to 6 of gestation. Stage 3. During week 8 to month 7 of gestation, formation of a specialized eyelid structure occurs. The fusion of the folds contributes to differentiation and development of marginal eyelid structures. Stage 4. Between 5 and 7 months of gestation, the eyelids start to separate with intermittent process. This may occur by apoptosis. Stage 5. Structural differentiation and maturation of the eyelids, which is usually complete between month 7 of gestation and birth. When the orderly sequence of migration and differentiation is disrupted, characteristic patterns of congenital malformation may occur. For example, cryptophthalmos, ankyloplefarum, and colobomas may occur. In the cryptophthalmos, eyelid folds fail to advance and cover the globe. As for the ankyloplefarum, eyelid folds fuse but fail to separate. With regard to the colobomas, eyelid folds are interrupted and adjacent tissues are unable to interact to influence tooth growth, maturation, and differentiation. Eyelid colobomas occurs 0.7 cases per 10,000 on birth. Unilateral cases are shown in sporadic cases, but Fraser syndrome, Gordner syndrome, and Treacher-Collins syndrome shows usually bilateral patterns. This is examples of Fraser syndromes and Treacher-Collins syndrome. Pathogenesis is multifocal. A coloboma may result from an error in ectoderm and mesodermal migration. Mechanical faults, such as amniotic band, may also cause compressive tissue destruction of the developing eyelid. In Gordner syndrome, a limbal dermoid may exert pressure on the eyelid, resulting in a focal failure of the eyelid development. Abnormalities in the movement of fetal growth plate during embryogenesis can also explain variations. Location in order is as follows: firstmost, second, third, fourth. First is junction of middle or inner one-third of the upper eyelid. Second is the central upper eyelid. Third is the junction of lateral middle one-third of lower eyelid. And the last one, fourth, is the junction of middle or inner one-third of the lower eyelid. These figures show the management of the eyelid colobomas. This figure shows the Cutler-Beard technique. Cutler-Beard techniques uses the lower eyelid to make the colobomal upper eyelid. So this picture shows the direct closure with lateral cantolysis. This picture shows the vertical advancement flap. Sometimes the colobomal area is very small. Blepharoplasty technique can be used. This is a small coloboma case in the upper eyelid. So this patient is reconstructed with a blepharoplasty technique. The design is similar to the blepharoplasty. First, lateral canthoplasty is made. After incising the skin like this, posterior lamella is removed with pentagonal excision method. This is the removed posterior lamellar tissue with pentagonal fashion. The defected area is reconstructed by pulling the medial and lateral tarsal plate with each other. After that, underlamellar is a little redundant. So a releasing incision is made laterally. Skin closing suture is similar to the normal blepharoplasty fashion. This picture is just after the operation. This is 1 week after the operation, and this is 2 months after the operations. The functional and cosmetical good results were obtained. To make this right, I appreciate with Dr. Hatem Tawfiq in Egypt and Dr. Rohit Saij in Nepal, giving me a lot of patient photographs. Thank you very much for your attention.
Thanks to Dr. Kaki for the great presentation. So if there is any question, we have a question for Dr. Kaki. What's the recommended patient age for congenital coloboma repair? So as Dr. Kaki is not here, if any one of the panelists would like to answer, please raise hand or just dig in.
Okay, I like to answer this question. The coloboma, if they are the corneal throaten, we may do it before 1 year old, but if there are no the corneal throaten, we just have the delay repair, like in the 2-year-old or 3-year-old. If the can you hear clear?
Yeah.
Yes.
Let's go on.
Yeah, I can hear you loud and clear.
Okay.
So are you done, Dr. Dong Mei?
Yeah.
Okay, thank you very much.
Can I also make a comment, Dr. Fazat, a little bit?
Yeah, please okay. Go
on. Then we have to see if there is the exposure of the cornea, and then make it abrasion or something of the exposure of the cornea. Because in my case, I have like 5 case. I did it like in 5 months, years old, and I choose the technique with Tenzel with modified. So it's easier, and also it's prevent the amblyopia if we doing culture birth period. But if we can delay it and the exposure, we just can see with the Bell's phenomenon. If it's good and the cornea is good, then we can delay. Thank you.
Thank you very much for good answers.
So we're going to move on to the next topic. And our next speaker is Dr. Dongmei Li from China. So as we all know, she is a current APSOPRS president, and she is a professor of Capital Medical University in Beijing. And her topic is use site in the management of congenital microphthalmic and anophthalmic socket. Please.
Good morning, everyone. So happy to meet a friend here. I'm Dongmei Li from China, Beijing Tongren Eye Center. I'm current president of APSOPRS. Today, I'd like to talk about a new insight in management of congenital microphthalmic and anophthalmic socket. I have no financial disclosure. Congenital microphthalmias and anophthalmic is a leading cause of the blindness. After birth, the patient will have the asymmetry, facial asymmetry, and patient will also have the narrow pupil fissure and contract the socket. If we don't give the intervention as soon as possible, patient will have the very severe facial asymmetry like the picture shows. We have conducted the digital evaluation of the orbit. Then we get the conclusion the main optic volume is linear with the age in normal children, age range 0 to 6 years, and the children children have the fast growth before the age of the 6-year-old, and at the years the 3 year of the age, the optic volume will reach near the 70% of the adult. So that means we have to give the intervention as soon as possible. For the intervention, the first we give the conformer and the prosthesis timely replace is the lifetime procedure, and also the socket orbit expansion. Here, I just introduce the hemispherical hydrogel expander. We will give at the age of 3 months to 1 year old. It's better before 1 year old. So this procedure, it's a very simple procedure. We just insert the hydrogel expander to the socket. Then it will expand the socket, also the pupil fissure. And then after the surgery, we just replace the hydrogel to the artificial eye 1 or 2 months after surgery. And then when the patient get to the 1 year old or the 2 year old, we give the spherical hydrogel expander to expand to have the optic volume augmentation. And here we just we use the conjunctival incision and dissect to the retrobarbal place. Then we insert the hydrogel expander to the intracorneal space. After we insert in the correct position, then we just close the conjunctival and teres and conjunctival. Here we can see the procedure very clearly. And in some case, we may cut the optic nerve, then insert the hydrogel to the intracorneal space. Then we just close the teres and conjunctival. This the B scan, we can see only the 1 week after surgery, the expansion will reach to the hydrogel will reach to the 90% of the final size. So it's the disadvantage of this hydrogel, too fast expansion. With the patient before and after, there's the injectable opto implant, the palette. So this the palette is we cannot replace the opto implant. So we choose the procedure to the patient need the less opto volume augmentation, and also in the older age of the patients. So for the procedure, first we give the injection of the local anesthesia and to get the symmetry of the two eyes. And then we can measure how much of the palette we need to insert the orbit. We just use the volume, the solution volume was divided by the 0.24, then we can get the number, how much number we need to inject. This the customer made injectable. We insert to the intracorneal space, and then we just insert the injectable, the self-inflating hydrogel pellet expander. Each time the injection, we only can give less than 10, and the total number less than 15, the pellet. And then after the 2 pellet insertion, we will remove a little bit to avoid the 2 nano of the intracorneal space. And after the final injection, then we give the 1 suture of the skin incision. Here, the patient before and after the patient, we can see the MRI skin, we can see the pellet in the intracorneal space. It's the very important step evaluation. The post-operative evaluation is very important. We give the 6 month the interval time for the evaluation. We will evaluate the opto volume, also the facial, the pupil, lens head. And it's very difficult to use the CT skin and MRI skin to evaluate the facial symmetry. So we choose the 3D skin, use the light to evaluate the facial symmetry. It's very simple and faster and no invasive. For the exchange of the opto expander, if the clinical impression is indicated, the opto expander was replaced with the 1 or 2 millimeter larger spherical. It's the very simple procedure. Just reopen the capsule, then remove the original one, then insert the large one. The patient, after 5 year follow-up, this patient after the 6 year follow-up with the several steps, and also the patient with more than 5 year follow-up. This also the patient with the many years of follow-up. Still, there are the complications like extrusion. Only in the first year, we may have less experience, so we have the 2-case extrusion. And for the migration, may have the 10% migration. If they disturb the artificial eye insertion, we will adjust the position of the hydrogel. For summary, the timely replace prosthesis, it will be the lifelong job, and also the time is very important procedure. Then the hemispherical expander for the socket expansion by the age 3 to 15 months, and orbital volume augmentation. When the clinical impression is indicated, we may replace with the larger spherical until 5 millimeter is reached. Thank you for your attention. Good morning, everyone.
Thank you, Dr. Doime, for the great presentation. So we have one question for you. And how do you prevent the migration of the pellets after injection?
The pellet, for the pellet is very small, so the migration is difficult to eject the migration. So for this, the migration, if in the retro barber is okay, but we have the 2 cases migrate to the subcutaneous. So we just remove, and then maybe the 1 month later we repeat the rejection, because it's very easy, just the local anesthesia. So if the migrate to the subcutaneous, we just remove. Only in the first year we have the migration, but for pellets, it's not easy to migrate.
So personally, I use a zigzag transfer when I put TrueCar into the skin and then conduct the retrobulbar space. I travel like a zigzag. I believe it may decrease the chance of the migration anteriorly. What do you think about that?
Yeah, I agree. Maybe just I will try later, just from the conjunctival approach. But I like to, until now, I like to use the skin approach.
And the other thing is that to make sure that you have put the pellets inside the actually deep orbit in the intracorneal space, not that much superficial, to make sure that you put TrueCar in the correct position and then push toward the correct position, the retrobulbar space.
Yeah. The just the retrobulbar place. So the palette is okay. No much migration. So only the two palette migrate. I only have the two cases, but and only two palette. So, but for the spherical, just the spherical hydrogel, sometimes maybe like the 10% of patient may have the migration.
Okay. So thank you very much, Dr. Dangmei. Great presentation. Thank you very much.
Thank you. So our next talk will be given by Dr. Akshay Nair from India. And Dr. Nair is a oculoplastic staff from Aditya Jyot Eye Hospital and Advanced Eye Hospital and Institute in Mumbai from India. So he's going to talk about 4-pedal evisceration for maximizing oidal volume. Could you please?
Thank you so much. The level of the talks has been really stellar till now, and I'm in many ways I'm going to bring down the level of the discourse because this is a very basic talk, and I'm focusing on a simple oculoplastic procedure that probably is our bread and butter because we do so many of these, and I'm just going to explain why this technique that I was taught during my training is something that I have experimented with along with different techniques and now come to embrace completely. I have no financial disclosures relevant to this presentation. Evisceration, of course, like we know, has multiple indications. It's done in different types of presentations of painful blind eye. It could be a post-traumatic eye, a prephthisical eye like we see here, which is completely atrophic, or it could be a staphylomatous eye post-trauma or multiple surgeries where the size of the globe has increased as compared to the normal size. And in both these scenarios where the globe size is smaller than the normal eye or when it is larger than the normal eye, we have the option of doing an enucleation versus an evisceration. But at the end of the day, what is the aim of surgery when we are faced with a patient like this? It's giving patient relief from pain when they do have pain. Once the globe is removed in whichever surgery we prefer, we need to add an implant so that we are able to maximize the orbital volume such that the size of the prosthesis is as small as possible. And we provide cosmesis using that prosthesis, maximize motility. And as is the case with every surgery that we do, the aim would remain to have minimal complications. So if we set out with these aims, you'd see that how this technique is fairly on the money in most cases. Now, there are different techniques, and I'll go through a few historical techniques or variations that are done by different surgeons. Ideally, of course, the indication for the surgery or the condition, the axial length of the eye, would decide the type of technique done and also the implant material that is being used. So traditionally, after eviscerating the intraocular contents, we would horizontally give relaxing incisions, detach the posterior, the optic nerve attachment, and within this scleral shell, with a few relaxing sclerotomies, introduce the implant. There have been different variations, including this one where, again, there have been anterior sclerotomies with horizontal incisions and a 330-degree posterior circular sclerotomy to allow for an implant. Other variations of this, like Long and colleagues described, was again posterior detachment of the optic nerve attachment, followed by a slight circumferential cut on the posterior edge of the sclera to allow for an implant to enter this. And you can see why in most cases the scleral cavity itself is being largely left intact, which meant that this would be a great procedure provided the size of the globe would be large or normal. And in atrophic or in thusical eyes, it may be difficult. Now, say, for example, you're faced with an eye which is, the size of the eye is something like this, where you're barely able to hook the muscles. So in this case, the music is not from my end. Yeah, thanks. So in most cases, we end up enucleating this eye because, as you can see, it's difficult to be able to get space in this. And that's why, in these cases, we would end up doing an enucleation. But when we look at what enucleation versus evisceration is, we can see that, there have been different papers and research projects that have shown that there is greater orbital disruption during an enucleation because there's, far more dissection in the orbit, which leads to fat atrophy subsequently. Similarly, the complex network of orbital pulleys within the orbit tend to get more damaged in enucleation. Enophthalmos is significantly higher in cases of enucleation versus evisceration. And also the fornix instabilities are more common following enucleation. So with all of this, we know that we'd rather have an evisceration for better functional outcomes compared to an enucleation. And that's where this four-petal technique really comes in, first described by Salles-Sanz and Sanz-Lopez, which basically is a quadrisection, a four-petal technique where you really literally make the sclera into what appears to be like a four-petal flower. It's easy to see why it gets the name. I'll quickly run through a video of what this technique is. We start off as we would normally would for any case of evisceration with a clean, thorough peritomy, where you make sure that you dissect the conjunctiva and the tenons from the edge of the limbus. I like to make pockets or with a general utility scissor between the recti muscles, and we see why, because each of these petals are attached to one of the recti muscles. A stab incision into the anterior chamber, followed by a keratectomy, which is performed just posterior to the limbus, such that a thin scleral rim is excised along with this. An evisceration scoop, this is fairly standard procedure for any evisceration, where we remove the entire contents, intraocular contents. Most often than not, in a post-traumatic eye, this would not come out in a single go. It comes out piecemeal, which is acceptable as long as we are able to make sure that all the intraocular contents are removed in toto, entirely. We use alcohol-dipped Q-tips to denature any residual choroidal tissue within the sclera and give a thorough saline wash, because any residual alcohol can later on cause significant inflammation within the orbit. Now, your assistant would grasp the sites of where normally the representative of each of the extraocular muscles, the recti muscles, and between two of the recti muscles is where you can go in and make these anterior to posterior large sclerotomies, which basically create four petals. Now, and when you posteriorly reach the optic nerve insertion, you need to make sure that it is completely detached, such that each of these scleral petals are independent of each other, and the only attachment that they have is to the recti muscles. Now, obviously, because there is a posterior detachment from the optic nerve, when the implant, and you can see this is a large 22 size millimeter implant, is placed within, it goes truly intraconal and becomes a true orbital implant and not just an intraocular implant. You can see that the coverage that you're able to obtain with the scleral overlap is thorough, and you have two layers of sclera that overlap each other, giving an added layer of protection from extrusion or exposure. And now you can see the horizontal flaps overlapping. And top of this, we also would have a layer of tenons and then the conjunctiva that make sure that there is added barriers of protection to make sure that it does not extrude. The conjunctiva I prefer to close with 6-0 vicryl. This is the tenons being closed in interrupted sutures. For the conjunctiva, I prefer to use a single purse string suture, again, a 6-0 vicryl suture. And as Dr. Grover said, it's important to make sure that at the end of the surgery, you would leave behind a conformer in place, because that would maintain the space anterior to the implant and make sure that your fornices are adequately spaced out. Here you can see a large size conformer is being put in with a simple suture tarsorrhaphy at the end of surgery. A couple of variations in this. I like to use a saline-filled syringe with a cannula and introduce it into the suprachoroidal space and drag it 360 degrees all around. In many ways, this is like a hydrodissection, such that a cleavage plane is created between the sclera and the choroid. And as a result of this, when we introduce the evisceration scoop, it becomes very simple, and you don't have, you can remove the entire vitreous body along with the retina and choroid in a single scoop without having to make multiple passes. How does it actually, come out versus a standard evisceration technique that we discussed earlier? Now you can see that we are able to put in larger implants, especially for phthisis bulbi. This was a paper by Rano where they used physical eyes, and the 4-petal technique really did well with the low rate of extrusion, because we're able to place a significantly larger implant because the posterior edge is of the sclera is completely open, and the implant becomes an orbital implant. How about quantifying that data? Here again, El Bakri had done this wonderful paper where they compared the size of the atrophic eyes that were being eviscerated to the contralateral normal eye. You can see that the 4-petal technique allowed an implantation of the implant, which was on an average close to 3 millimeters larger than the normal eye. With a 4-petal technique, you're able to address everything that was discussed earlier: the volume, the superior sulcus deformity, the enophthalmos, as well as get adequate amount of motility, which is basically what patients look for at the end of the day. So the 4-petal evisceration technique has greater applicability, especially in physical or atrophic eyes. It's simple, it's reproducible. In many ways, compared to an enucleation, my opinion is that it is a little more physiological, as contradictory as that statement is. It, in the long term, has fewer complications and gives good motility. So it, in many ways, is a flower with 4 petals for all seasons. If there are any questions, I'd be happy to take them.
Thank you, Dr. Akshay, for the great presentation. Is there any question?
I have a question for you. So personally, I only use that full fetal technique for the patients with phthisis bulbi, which is very severe one. But in other cases, I usually stick to the conventional technique because I have some concern about the migration of implant after that particular technique. So what do you think about it? And do you usually do this technique for all evisceration cases?
Yes, actually, that's a great question, because one of the complications is migration followed by extrusion or exposure. This is my fallback technique for most eviscerations, and I have, yes, occasionally we do see in some cases that there is a migration, but surprisingly, it's not the normal sized globes where I end up having migration. It's actually the fascicle eyes that I find that are migrated, because I find that the scleral flaps are, even though they give good anterior coverage, posteriorly there is a slight gaping that occurs between the two petals, through which a smooth non-integrated implant may just migrate. So usually it's an inferolateral migration that I see that requires removal and probably a secondary implant or a DFG. But yes, I prefer, as you can see in that video, this is my go-to technique for all eviscerations.
So actually, there is a question for you as well by Dr. Shu Ho, asking that, is there a need for wrapping non-porous implants with vertical mesh and anchored to scleral flap to prevent migration or not?
Right. So actually, there was a paper that was published in ophthalmology a few years ago that actually demonstrated this technique. In our experience, we've used silicone and PMMA. We haven't found a surprisingly alarming rates of extrusion or exposure in cases that were not wrapped, and because that is the only technique that we use. I don't have any experience with wrapping, but given that we have had such low complication rates in unwrapped PMMA implants, it's not reason enough for us to shift. And I'd like to hear if there are any other panelists who've had experience with wrapped non-porous implants.
Thank you, Akshay.
Thanks.
Thank you.
So,
yeah, we're going to move on to the next topic. Our next speaker is Dr. Darmayanti Sisyoyo from Indonesia. Dr. Sisyoyo is a consultant of ophthalmic plastic and reconstructive surgery, JEC clinics and hospitals from Indonesia. So her topic is one-stage surgery in blepharophimosis syndrome. Dr. Sisyoyo.
Thank you, moderator and co-moderator. Good morning. I will talk about one-stage surgery of blepharophimosis syndrome. I allowed the participant to capture my surgical video. Blepharophimosis syndrome, the actual name is BPIS, blepharophimosis, ptosis, and epicanthus inversus syndrome. Four major features: blepharophimosis, epicanthus inversus, telecanthus, and ptosis. There are two types with systemic association with premature ovarian insufficiency, and type 2 with four major features alone. Three clinical appearance of blepharophimosis syndrome: classic appearance, accompanied by a shortage of skin, and then the type 3 accompanied by low place lateral canthal ligament. Additional findings: poorly developed nasal bridge, lower lid ectropion, and loop ear helical rim malformation. We have to know normal proportion of the eyelids. Normal proportion of the eyelid, horizontal fissure, right eye, intercanthal distance, and left eye should be the same, each 1/3. So to plan for reconstruction, we measure horizontal fissure right eye, intercanthal distance, and horizontal fissure left eye divided by 3. So we will have new horizontal fissure right eye, new intercanthal distance, and horizontal fissure left eye 1/3 each. Reconstruction plan. Reconstruction plan. First, measure the horizontal fissure right eye, for instance, 24 millimeter, intercanthal distance, for instance, 36 millimeter, left eye, for instance, 24 millimeter, then become 84 millimeter divided by 3, it becomes 28 millimeter for new intercanthal distance, new horizontal fissure. So first, we measure for new horizontal fissure, 28 millimeter until here, it is for lateral cantotomy. Then second, we mark for lid medial to lateral until the point here, and then mark for new intercanthal distance from midlinus, 14 millimeter left and 14 millimeter right, 28 millimeter, and then mark for wide incision, and then mark for supraciliaris incision for tunnel for frontalis suspension. Highly recommended Wi-Fi plastide. Why? Because after medial canthal ligament was shortened, there will be excessive skin at the area between the nose and medial canthus here. So this is excessive skin, cut excessive skin. If double Z plastic, it's difficult to excise excessive skin with several skin incision. Telecanthus caused by long medial canthal ligament, so it is mandatory to shorten medial canthal ligament. By the medial periosteum of the medial canthal ligament, by the lateral medial canthal ligament, and then tie the sutures. See here, let's take a look to the normal lower eyelid. It is straight and tight lower lid margin, but here all the blepharophimosis syndrome, you see here it is slight curve and loose. So it is mandatory to do lower lid margin tightening by the lateral marginal arc, by the inferior end of the tarsal plate, and then tight the suture. Don't do lateral canthoplasty. Ptosis due to maldevelopment of levator muscle. If there is levator muscle, we can do maximal levator resection beyond ligamentum lignar. If no levator muscle anymore, we do frontalis suspension. I prefer autograft fasciolata for the lateral thick. The procedure here in the surgical video. And if we want to get a more beautiful cosmetic reason, we can flat nose bridge augmentation, just flat nose bridge augmentation, because usually the nose tip is high enough. In the long time, I do with bone graft or cartilage graft, but now I prefer synthetic material, silicone. This is silicone cuff like this, just to augment the flat nose bridge. Insert the silicone, rest it on the top of the nose bridge bone. This is the video. Measure the horizontal fissure. Mark here for the horizontal fissure, cut lateral cantotomy, and then mark for lid fold until here. And then this is for new intercanthal distance. This is for Y incision. And then cut the skin. Cut the skin with scissors. And then dissection vigorously until all the medial here, until it is loose. Then dissection suborbicularis here until the tarsal plate was exposed. Dissection superiorly. In this patient, unfortunately, I do not find any levator muscle. Cut the septum here until we can feel loose. This is also dissection here until we feel the skin is loose. And then bite the periosteum of the medial canthal ligament, and then bite the medial canthus here, the medial lateral end of canthal ligament, and then tie the suture. Then You see here there is is here by major sebelum segini. Cut the excessive skin here. We should make adhesions here to get a more beautiful medial canthus. So posterior position of the medial canthus and the submedial canthus. This is for lower lid tightening by the marginal arc of the lateral periosteum and then by the lateral end of the tarsal plate tied to suture, and then suture for the lateral canthus, lower and upper. And then this is for fascia lata suspension. Create a tunnel from the supraciliaris incision. This is fascia lata from the lateral tip. At the fascia lata, suture to the tarsal plate. It is in the central first, center of the eyelid. Make sure that the needle do not pierce the conjunctiva. I have to suture in the lateral, in the lateral here. Make sure do not pierce the conjunctiva, the needle. I have to suture, and then here also. Make sure the needle doesn't pierce the conjunctiva, yes. Right, the suture, and then pull the fascia lata to the frontalis. Before, create a lid fold, skin, fascia lata, and skin. 3 suture, and then the rest is just for skin incision. Unfortunately, this is after, and this is just for frontalis suspension, because before the frontal area was not captured. This is to create a tunnel for fascia lata to pass through this tunnel. This is the maneuver for widen the tunnel until the fascia lata can pass the tunnel. Then after suture the fascia lata to the tarsal plate, pull the fascia lata to the frontal, to the supraciliaris incision. This is create lid fold, and then suture the fascia lata to the frontalis muscle. Fascia lata, frontalis muscle, and fascia lata with the position of the vertical eyelid fissure in normal position. Central, lateral, and medial. This is to the fascia lata to the frontalis muscle, to the fascia lata and the lateral frontalis muscle, and then cut excessive fascia lata, suture the skin. This is I want to show how to do a partial rhinoplasty. It's a simple procedure, dissection from to create a room for the implant from the nasal bone bridge. This measure the implant, mark the implant, the lowest part of the implant, mark the cuff the implant like this. Cut the cuff the implant to match for the, this is okay. Here. Then insert the implant and rest it on the top of the nose bridge bone. So the nose bridge bone will be augmented. Fix the implant with the sponge and then remove for 3 to 5 days. This is one-step surgery. This is before and this is after with partial rhinoplasty here. It is good cosmetic result just with simple procedure. This is before and this is after. There is forehead wrinkle after, no forehead wrinkle. Before slightly curved, loose lid margin, but after straight and tight lid, lower lid margin. So blepharophimosis syndrome with Wi-Fi plus tie, shortened medial canthal ligament, tight and lower lid margin. If necessary, partial rhinoplasty and front ptosis correction with blepharoresection or frontal suspension in one-stage surgery, you'll get good cosmetic result, time, and cost efficiency. Thank you very much for your attention.
Thank you very much. Great presentation, and we love that technique. Thank you very much. So, is there any question for?
Yeah.
Oh, I have a question.
Yes,
yeah.
Dr. Lee.
That? Yeah. For the very small pepper fissure, and there's too much tension. So if we have in the one stage, there too much tension. If you want to expand vertically, horizontally, and also the vertically, it will be very difficult. So for the very the small pepper fissure and which the much tension, how the Dr. Damayanti, how do you think? For me, I like to for the very small pepper fissure, I like to do 2 stages. So I like to ask her the question.
Thank you, Dr. Dorme. I think the important thing is we have to dissect the skin and orbicularis muscle in the upper, like this, in the superior part, and then we have to cut the septum. It will be loose, and then dissect vigorously to the medial side until we expose with ligamentum medial canthal ligament, and inferiorly we dissect and vigorously dissect and cut also. So we can have loose skin, and then in the upper also we can have loose skin also. I think I just tried this and it worked.
May I ask a
It
question?
vigorous dissection.
Yeah, please, Ashok.
Thank you.
Dr. Damayanti, so nice to see you.
So nice
Great
to see you
presentation.
also.
Great presentation. Really enjoyed all the innovations. The results are excellent, especially on the nose. I also had a little question about the most severe cases. Would you consider doing a transnasal wiring in the most severe cases? Because that would give possibly a longer lasting result in those severer cases and a greater, deeper placement of the medial canthus.
I never do transnasal wiring because I think it is slightly difficult, take time. But with this procedure, bite the medial end of the lateral canthal ligament. Be sure that we bite the periosteum and then bite the lateral end of the. I think it's good. And then the second important thing is we create adhesion between the subcutaneous tissue from the medial canthal ligament until the subcutaneous tissue of the noose in the posterior bridge noose. So it will get a posterior aspect of the medial canthal ligament.
Thank you.
Medial canthus, medial canthus. Thank you. Thank you, Dr. Ashok.
Dr. Damayanti, thank you very much again. I have a question for you. Do you have any indication for actually doing like 2-stage operation for this kind of patients, like very small babies, like infants with severe ptosis? Do you have any indication to go for 2 stages instead of your fantastic technique for 1 stage?
I always do in 1-stage surgery. I never do for 2-stage surgery. I think for patient, it's also cost time efficiency.
So
And
small
then-
children, you cannot use facial lata. So it seems that you may use silicone rods or something. So considering the tension that Dr. Dong may address, do you believe that using that kind of material and tension by the medial cantoplasty can cancel the effect of the upper eyelid opening?
Formally, I think that, but I tried to do the fascia lata maybe in a 3 months old baby. I find the fascia lata.
3 months.
Just try. Yes,
Wow.
you can find the fascia lata. Okay,
So
thank you.
in the same line with other questions, do you customize the level of upper eyelid when you do the surgery based on the severity of the ptosis or some other conditions? Or do you overcorrect that?
I always try to do the vertical fissure until it's around 1 millimeter from the upper limbus. So maximal.
A quick last question. Sorry. Go on.
Okay, thank you.
I wanted to say that we have a very quick, actually we have a short question, and it's actually asked, the question is that, do you have any issue of scarring, usually such extensive incision from the upper eyelid blepharoplasty onto medial nasally? There is lots of scar issue in my Chinese population. Do you want to comment on that question?
For scarring on the medial part, yes, sometimes, yes. After 2 weeks, usually I inject Kenacort, triamcinolone, and oradexone, dexamethasone to that scarring. But yes.
Okay.
Thank you very much.
I'm so impressed with the very nice surgical outcomes. So we're going to move on to the next topic. The next talk will be given by Dr. David Honglei Liu from China. Dr. Liu is a vice president of APSOPRS and chairman of the Center of Oculoplastic Surgery and Orbital Disease from Jian Xiaotong Hospital University in Xi'an City, China. So his topic is the treatment of orbital apex tumor. David?
First, I'd like to say thank you to the chairman and the organizer to give me opportunity to share our experience about the treatment of strategy of orbital apex tumor. I'm David from Xi'an Jiaotong University. I have non-financial disclosures. We all know orbital apex is a very congested structure. They have many important structures there. They have the optic nerve, artery system, vein system, and some nerve system. There are about 4 kinds of apex orbital modalities, such as the trauma of the optic nerve, TON, and the apex syndrome caused by the inflammation and the trauma. Another one is the artery aneurysm. Some was the apex foreign body, such like I show a slide here, the mental foreign body at around the apex. And another is the apex tumor. So in our clinic, majority apex tumor is the cavernous hemangioma, and around 10% is schwannoma. The apex orbital tumor really different from the tumor located in the anterior part of orbit. They usually asymptomatic and consistent. People usually, finally, they have the visual acuity decreased, or say they have the large visual field defect. They came to the clinic, or they have the headache. They do some the CT or MRI scan. They found the orbital tumor. The examination for the apex tumor usually include the basic examination, and we usually include the orbital CT scan and the MRI for the with contrast enhancement. For the subspecialty examination, we usually use the examination of degree of insolvency, and we do the whole medical recording for the patient, pre, intra, and post-operative image of the patient. There are 3 kinds of treatment for orbital apex tumor. One is the follow-up, just because some tumor do not have any influence to the function of the eye. So we just keep on the follow-up for the patient. The second method is the surgery. We have introduced later what kind of surgery we will choose. The third one is radiotherapy, such as the gamma knife for the apex tumor. So the surgery for the apex tumor, we usually use the classic method for the total resection of the tumor. The second one is when we expose the tumor, we do not resection the tumor. And then wait the result. The third method is endoscopic surgery, and another method is craniotomy. I will introduce later. We have the method we call deepest lateral wall orbitotomy. It's introduced by my director, Professor Li Huaxiao. We do this lateral wall orbitotomy, go to the deepest part, expose the dura. If we open the periosteum here, then we just reach the apex orbit. So we use the high magnification loop and with LED lightning. Here we show we go to the end of lateral wall, expose the dura, then here, open here is the superior orbital fissure. So I will present one case of my in my clinic. The patient have around 2 years visual decrease, but a misdiagnosis as retrobulbar neuritis. We can see with the MRI, we found a tiny tumor at the right apex. Here is the surgical view of a CT scan. So we do the lateral orbitotomy. We total resect in this around 7 milliliter apex tumor. Another case we found here, we can see the patient have a in T1, we can see the tumor just like this T2. With the enhanced, we can see it's maybe the cavernous hemangioma. But from a CT scan, we can find this tumor have a erosion of the lateral wall bony structure. Here is the coronal view. A surgical view, we can see even the roof of the orbit have the erosion. So we use the endoscope, we separated from here, we found the bony piece here. The tumor just located here. After we removed one large tumor, we found still another small one still there. So if you remove just one tumor, you must examine carefully to whether there have still another tumor remain. The second method is the intralesion scalar therapy for the apex tumor, just because some patient and they worry about the complications caused by the orbital apex surgery. So we just do the deep lateral wall orbitotomy, expose the anterior surface of the tumor, then we do intralesion scalar therapy. The medicine we used is the pinamycin or say blamycin. The tumor still remains in situ, and we just irrigation with the medicine. So here is the patient with 4 years of swelling of the left upper eyelid, and we can see she is a typical lipoangioma, and the tumor surrounding the optic nerve. So we cannot resection the tumor totally because maybe cause the visual acuity loss. So we just irrigation with the blamycin. So we expose the anterior surface of the tumor, we irrigation with the blamycin. So we go quickly at the video. We do the lateral cancerotomy first. Then we do transconjunctival approach, expose the anterior surface of the tumor. Then the irrigation with the blamacin for 3 times and remain the blamacin inside the cavity of the tumor. So this is a 3 times irrigation. We can see the color is not the same. And this is 6 months appearance of the patient. So after 6 months, we can see only here have the ghost structure of the tumor. We just see MRA first. So it's have a very great effect to decrease the tumor. So another method for the surgery is the endoscopic sinus surgery, just because it depends on the location of the tumor. If the tumor located in the nasal side of the nerve around the apex, we will choose the endoscope system. Sometimes some doctors like to use navigation. I think it's a very minimally invasive surgery. So we have a case, they have 5 years diagnosed as left optic nerve atrophy, but in fact, with the MRI, we can see here have the tumor around the post part of ethmoid sinus. So here you can see from MRI, they have the contrast enhancement here. So we do endoscopic surgery to totally resect the tumor from the nose. So the patient after 2 months, the visual acuity came back around 52 to. So another choice for the surgery is the craniotomy for the apex tumor. Why we choose the method like this? Just because we can see this tumor like this. It's located here. Even we remove all the part of lateral wall, we can see or we can reach only the 1/3 part of the tumor around here. Only 2/3 of tumor we cannot reach. So I choose the craniotomy for the resection of the tumor, and the pathological diagnosis for this tumor is the hemangial parasite tumors. So it's have a very severe bleeding when we do the surgery. So for the summary, we do the deepest lateral wall orbitotomy for the apex orbital tumor, and some patient, if they worry about the complications, we use the in situ tumor insulation scalar therapy. And if the tumor located in the nasal part of the optic nerve around the apex, we choose the endoscopic medial apex tumor resection. For another choice is the gamma knife radiotherapy for the patient, just because we do not do any surgery. If the doctor have a very great experience of the gamma knife, I think it's very safe and most effective compared with the surgery. So we can choose different kind of method to for the treatment of the patient. Another is the follow-up, just because if they at the beginning a very tiny tumor, so if we very high risk of the surgery, we can choose the follow-up for the patient. For the endoscopic resection, I think we should have a very good choice for the location of the tumor. If it's have a good location, it's should be a very mini invasive surgery for the patient. And we should have a very good ability to analysis of the CT MRI image of the patient to make a decision what kind of method we will choose. And if you choose the endoscope surgery, you must have a very good skill to use the endoscope to do the surgery to avoid complications such as the damage of rectors, damage of the cranial skull, and all the care we take is to avoid the relative complications. Thank you for your kind listening. Thank you.
Thank you, Dr. David. So we need to move on fast because we have a time limit. Dr. Hussain, can you please introduce the next speaker?
Yes. Our next speaker is Dr. Milind Naik from India. The subject is single-stage repair of palpebral neurofibromatosis with severe ptosis. As we all know, Dr. Naik is a professor of University of the LV Prasad Eye Institute. Dr. Naik, please.
Thank you. Am I audible and is my slide visible?
Yes.
Well, at the outset, I would like to congratulate the APSOPRS for this successful third webinar. Congrats to Dongmi Lee and Unia. The planning for this meeting has been excellent and the talks have been very educative. It's an honor to be a part of this program. So I'll be talking about single stage repair of palpebral neurofibromatosis with severe ptosis. Neurofibromatosis, as we all know, comes in various shapes and sizes. You could have cases where there's just a mild involvement of the upper eyelid temporal aspect to the extent where they could have functional and gross cosmetic issues. There has been a lot of literature on how to manage the bony components of neurofibromatosis, but there is very little literature about or guidelines about how to manage the eyelid components, especially the aesthetic and functional part of it. So in this regard, if you were to search the literature, there are very few papers which talk about how you would manage these cases. I have come across a couple of reports which focus only on the eyelid or the soft tissue. Personally, I used to do a staged approach a couple of years ago where I would first address the NF component, whether the orbital or the palpebral, then deal with the ptosis and the canthoplasty and so forth. Lately, I've been thinking about how we can include all these in a single stage and what could be the challenges for the same. So this is a very short retrospective case series where we included only the palpebral NF, which had severe ptosis, by which I meant levator action more than 4, which is recorded, or the pupillary axis covered. And we did not really address the bony component in these patients because these chosen cases had minimal bony component, which was obvious cosmetically. So here is case number 1, a 71-year-old man, and my first thought was that he should just manage with his left eye, but he was very keen to fix this because his grandchildren were scared of him. And here is the excessive laxity, not only in the anterior lamella, but the posterior lamella. And in upgaze, you can see that we cannot record any form of elevator function there. So in the surgery, we first decided to measure from the other eye. Is my video visible?
Yes. Yes.
Oh.
Very nice.
So we're replicating the measurements from the other eye. So I'm marking a 35 millimeters on this side just to make sure there's a little excess. Then I mark the mid-pupillary or the lateral pupillary border. Then the new lid crease and its distance as compared to the other side. And obviously there's also vertical laxity or vertical excess. So a blepharoplasty incision just so that we leave the same amount of vertical height of skin at the end of the procedure.